Welcome to the Rare Advocacy Exchange. This is almost the last session in a year-long series we've been doing. So hopefully you've tuned in for some of those in the past. And if not, if you've missed them, the same page that has the way to register for the future session next month is the same page that has the recordings of the past sessions. So if you're interested in seeing a session you missed, you still can do that. Today, obviously, the September 18th session, you're here. If you're in the right place, if you were looking for our panel on getting a precise diagnosis is critical for children and adults. We've got a great panel for this coming up. We, of course, couldn't do any of this without our sponsors. All these generous sponsors made this possible. Thank you to all of them. And actually, one of them, Cody Barnett from Illumina, is here to introduce some of the context for what we'll be talking about today. So with that, I would love to introduce Cody Barnett, who's in patient advocacy for Illumina for United States, Canada, and Latin America. Cody, the floor is yours.
Thanks, Daniel. Hi, everybody, and welcome to today's webinar. My name is Cody Barnett, and I work in patient advocacy at Illumina, where our mission is to improve human health by unlocking the power of the genome. And I'm honored to be here with you to discuss the importance of getting a precise diagnosis. I also want to thank Global Genes for creating space for critical discussions like this through their Rare Advocacy Exchange. This series is about leadership and making sure that the rare disease community has the leadership it needs to rise to the challenges of today and tomorrow. And our topic for this afternoon, getting a molecular diagnosis, is foundational to that goal. For individuals living with a rare disease, a timely and accurate diagnosis isn't just a milestone, it can be a lifeline. It can mean access to the right treatments, support services, and clinical trials. It can mean fewer unnecessary procedures, less uncertainty, and ultimately a better quality of life. Just as importantly, a diagnosis unlocks connection. It links individuals and families to others who are walking similar journeys, creating community, understanding, and shared hope. And increasingly, diagnosis is the gateway to precision medicine. With a molecular diagnosis, research is accelerating, and we are beginning to unlock targeted therapies, such as gene-based treatments that are reshaping how we think about and treating rare disease. And so for many, the journey doesn't end with a diagnosis, it begins. However, we all know that for too many families, the path to a diagnosis is long, complex, and filled with uncertainty. It can take years of medical visits, misdiagnoses, and unanswered questions before they finally receive clarity. These barriers are real, and they remind us why advocacy, education, and real change are so urgently needed. Despite these challenges, we are seeing progress. For example, in June, the American Academy of Pediatrics released a clinical report that recommended whole exome or whole genome sequencing as a first-tier approach for children with global developmental delay, when the likely diagnosis isn't clear. This is a major step forward. It signals that the field is starting to recognize the value that a molecular diagnosis brings to patients and their families. It signals that the sea may be changing. But I want to be real with you. Getting a diagnosis is still not as straightforward as it could or should be. And that's why today's conversation is so important. We'll hear from experts and advocates who are working to make diagnoses more accessible, more accurate, and more equitable. And we'll explore how each of us can help drive that change. So thank you for being here, and let's get started.
Thank you so much, Cody. And we have a poll. So here is our poll question. What do you believe is the most significant benefit of receiving a genetic diagnosis? Let's see. We're looking like the top result at about 50%, going up and down a bit, is enabling access to tailored therapies and support. Second most seems to be guiding long-term care and management decisions. And I'm sure our panel is going to cover quite a number of these reasons and benefits for getting to these kind of diagnoses that are a little bit more precise than a system or a symptom-based diagnosis would be. And I would now like to introduce our wonderful moderator, my friend, rare disease mom, CTNNB1 mom, and probably known to many of you as the fantastic host of the podcast Once Upon a Gene, Effie Parks, and she will take it from here and introduce the rest of the panel.
Hello, everybody. Thank you so much, Daniel. I'm so happy to be here. My name is Effie Parks, and I'm the host of Once Upon a Gene podcast. But most importantly, I'm a rare disease mom. My 9-year-old son, Ford, has a rare genetic condition called CTNNB1. And like so many families, we've experienced so much uncertainty and wrong turns and waiting for answers to finally get his precise diagnosis. And that moment changed everything for us. And not because it gave us a cure right away, but because it gave us clarity, it gave us connection, and it gave us a way forward. So that experience is definitely one that fuels my advocacy work, and it's why I'm so grateful to be here with you today on this specific topic. The panel, like Daniel said, is called Getting a Precise Diagnosis is Critical for Adults and Children. And I really think that that captures the heart of what we're all trying to accomplish together, because too often families get stuck, perhaps with a misdiagnosis or an umbrella diagnosis or what have you, but those labels don't tell us why. And why is the condition happening is so important. Without knowing the why, families miss out on treatments and trials and basic changes in their daily life and in their medical care that can make a huge difference. So today we're going to hear from 3 awesome experts who are all driving change from the clinic, from the research, and from the tech side. So we're going to talk to each of them about the barriers, the breakthroughs, and the hope that comes when families finally get that precise diagnosis. And just as importantly, we're going to dig into why it's critical to keep searching for these answers and why this answer is so important and powerful, and how it connects these families to the right communities, opens doors to clinical trials, and provides information for family planning, and again, bringing that relief from uncertainty. So I don't see Dr. Gramella yet. So let me know if he's here, Daniel. So I'm going to start with Lucas. Lucas.
He is here.
Oh, perfect. Okay. Lucas, you founded Probably Genetic to reimagine the diagnostic journey. So I'd love for you to introduce yourself. And can you tell us what the gap was that you saw in traditional testing and why you felt families needed another way?
Yes, thank you so much, Effie. It's great to see everybody, and thank you to Daniel and Nicole and Cody for creating this opportunity. Yeah, I'm the CEO and co-founder of a company called Probably Genetic. As Effie said, before doing that, I did my PhD at Oxford, and I worked on a really large rare disease study called the 100,000 Genomes Project, amongst other things. And one of my core insights from the 100,000 Genomes Project was that the patients who made it into that study were the lucky ones who encountered, a phenomenal physician or a scientist who said, I don't just think that your child has cerebral palsy. I think this might be an underlying genetic condition and we need to get them tested. But that's the lucky patients. Most of them don't make it into those studies, and most of them don't encounter these amazing specialists. And at the same time, most of those patients or their caretakers spend time online and try to piece together the diagnostic journey themselves and, Google cerebral palsy and Google seizures and Google other phenotypes. And the idea behind the company was if patients and their caretakers, mostly moms, already do this, why can't we build a platform that finds these patients on the web? So, for example, if Effie had Googled cerebral palsy, then the idea was let's make sure she can land on our website. And then on our website, we should hear what Effie's got to say about the patient. So we use AI to characterize the patients and try to figure out what might be the underlying cause based on Effie's description and based on photos and other data that we collect. And then we also pull the electronic health records of those patients when they're on the website with their consent. And then based on that, we make predictions. We try to figure out, might this be a CTNNB1 patient? And if the answer is yes, we send them a sample collection kit, we sequence their genome, and then return a diagnostic result to the family. And they can do it all from their phones, and it's all free, and they don't have to figure out how to pay for it or even figure out that genetic testing is a thing. That was the idea behind it.
Gosh, wouldn't that have changed some of our lives a few years ago if you were there, Lucas? Thank you so much for that intro. I really appreciate it. Dr. Garamella, I haven't met you yet. Welcome. I'm excited you're here. You're a nephrologist who has seen firsthand how genetic insights are reshaping kidney care. Can you please introduce yourself and share why you believe a precise diagnosis is critical for treating kidney diseases today?
Thank you, Effie. Thank you for having me. I'm Pranav Garimala. I'm a nephrologist, adult nephrologist by training, and I lead a kidney disease program focusing on polycystic kidney disease, which is the most common inherited genetic cause of kidney failure worldwide. And so this got me interested in the kidney disease aspect of genetics, and now I am more interested in ultra rare and rare kidney diseases and getting to a precise diagnosis. And you brought up a very important term, which is an umbrella diagnosis. And perhaps in medicine, the most common umbrella diagnosis I see is chronic kidney disease, which is not really a diagnosis. It's just telling someone that they have a problem. And understanding the root cause of that really determines how we treat people. And over the last 10, 15, 20 years, we've started to make, phenomenal progress into understanding the cause of a lot of these kidney diseases. And as I'll highlight later on, we have a lot of kidney diseases now that we have known genetic causes for. In up to 20% of people now who previously were diagnosed with an unknown cause of kidney disease, we can actually pinpoint a genetic diagnosis. And this is something that work that the American Kidney Fund, where I'm the chief medical officer, has been really pushing over the last few years. We have historically had a large patient pool that we provide charitable assistance to for their kidney care. And when looking at the data from our own data set, we found that up to 20%, 15 to 20% had kidney disease diagnosis as unknown. And as we started looking across the spectrum and across kidney failure data sets, we found that this was not an isolated event. And this is where we've partnered with a lot of patient education portals through companies that provide genetic testing to really educate providers that calling someone as having chronic kidney disease is not enough. You have to give them an etiological diagnosis. And if you can't, you need to refer them out, and what impact that has, not just on the patient, because they know what that means, but what that means for their family, for their counseling, for their planning, and prognostically, and perhaps the ability to participate in clinical trials. And so this is what we at the American Kidney Fund have really been advocating for over the last few years.
That's amazing. And that makes me just think of all the chronic illness patients that we have so close in our rare disease community and how they're always piecemealing all of these things together and are constantly searching for answers, but also drowning in all of these symptoms that they're experiencing without a proper name. Dr. Kruer, welcome. You have spent years asking why neurodevelopmental conditions happen, rather than stopping at broad labels. Can you please introduce yourself and explain what drew you to keep digging deeper with those questions and how it's changed the way that you think about a diagnosis?
Absolutely. Thanks so much, Effie, and thanks to the organizers for asking me to be part of this exciting discussion. I'm a physician scientist based out of Phoenix Children's and the University of Arizona. And I split my time between seeing and evaluating, treating children with a broad variety of neurodevelopmental and neurological conditions, and spending time running a academic research laboratory where we try to dig deeper and make improvements in both diagnosis and treatment. And so based on my training and my interests, I've really worked at the intersection of rare neurological disorders and genetic disorders and neurodevelopmental disorders for quite some time. I got my start about 15 years ago doing rare disease neurogenetics and doing mostly work trying to understand the fundamental drivers of some of these rare diseases that we knew about but didn't understand very, very well. Over the last 10 years, I really spent a lot of my effort and that of my wonderful collaborators and colleagues in the lab. We've really been focused on trying to understand cerebral palsy as a specific example of a well-known and relatively common neurodevelopmental disorder. But when I first started working in cerebral palsy, what I had been taught and what many of us thought in the field was that cerebral palsy is not ever a genetic condition, or is very, very seldom a genetic condition. And digging into that a little bit further, we've challenged some of those assumptions. And so we've really our group and a number of others have helped to characterize this very complex genetic landscape of cerebral palsy. We've helped to discover and characterize new genes that lead to CP, and what's been very gratifying is to see that actually impacting my patients and their families in the clinic. on a regular basis. More recently, we've been moving and pivoting our research somewhat in, we're still working very much in rare disease diagnostics and in the cerebral palsy space, but we're increasingly interested in the therapeutic implications. Okay, if we have a genetic diagnosis, where does that take us? And so that's been a very exciting recent development.
Yeah, we're very excited about your work. I'll start with you, Dr. Kruer, since we're there right now, and we've mentioned umbrella diagnosis, and I'd also like to introduce dual diagnosis, both really important. Can you kind of explain that for anyone who hasn't really heard that term and what it looks like? For example, CP and finding the precise genetic diagnosis. Can you explain why it's important to have them and why they're different?
Yeah, I'd be happy to. And so this is something that's near and dear to my heart because I trained as a child neurologist and a developmental pediatrician. And so I do think that there are values in these umbrella diagnoses. But to this day, things like cerebral palsy, conditions like autism, epilepsy, or intellectual disability, these are very common childhood and adult neurodevelopmental conditions that really affect people across a lifespan. But they're fundamentally diagnosed based upon their clinical presentations. One of the things we still emphasize to our trainees is that these are clinical labels. They're clinical diagnoses that we make based upon the patient that's in front of us. And I think that's very important, especially in a rare disease context. Sometimes the broader community, the medical community, the school, they might not know about a very specific genetic diagnosis. But if you say, okay, well, this child has autism, that's something that a lot of people can get their head wrapped around. So I think there is a lot of value in that. But I also think that we have a lot of evidence that there is additional value in asking the follow-up question, why? Why does this child have autism? Why does this child have cerebral palsy? And I think that there's a huge overlap with genetic contributions to these conditions. We now know, for example, that even though heuristically for years we've always associated cerebral palsy with birth injuries, lack of oxygen at birth, the most recent data actually indicates that genetic contributions, genetic causes of CP are probably far more common than birth asphyxia, which is still a surprise to most people out there.
Thank you, Dr. Kruer. Lucas, I'd like to talk about the big question you probably get initially at all points in time, which is the transfer of information from these families to using your AI platform and how their data is safely kept and what you're doing with it in places like probably genetic.
Yeah, I think there's a couple different sides to safety. The first one is like, how does the infrastructure work? And then the second piece is, what are the use cases we have for it? And on the infrastructure side, we have to be super buttoned up. We have had to build a HIPAA compliant system that's also GDPR compliant and that has all the encryptions in place that you need to have for super sensitive patient data so that people can trust it. We also have to build protocols so that patients can delete their data easily. If people decide they don't want to have their data in the system anymore, they can just notify us and we delete all of the data. That's sort of the like software architecture side of things. And then on the use cases side, that's a really important question. We cover all of the stuff directly on our website, and then as part of an informed consent flow that patients use. The main organizations we work with are biotech and pharma companies, and specifically within those units, we work with medical affairs and commercial teams. And their job is typically find as many patients as possible because we either want to put them on a trial or we want to put them onto a treatment if a treatment is available. That's their single use case. Every team, every company has one or many teams like this. And they, from us, really want two things. The first one is they want to know which physicians are treating these patients. And that's why, as part of the intake, we ask the patients, who are your doctors? And patients can choose to give us that information or they can choose to not give us that. It's optional. But if they give us the information, we share the physician information with those pharma companies. And then the second thing they want from us is if and when a trial or even a treatment becomes available, they want us to be able to reach back out to those patients and tell them, we gave you a CT-NNB1 test result 3 years ago, and it's now 2030, and a gene therapy has just been launched for CT-NNB1. You should be aware of the fact that this treatment's been launched, and because of that, patients can give us their opt-in consent that we can reach back out to those patients and then let them know the therapy just went live or there's a clinical trial. Those are the two main things those pharma companies care about. In addition to that, we share other de-identified data. For example, they want to know what are the different types of variants we found in CT-NNB1, or what percentage of CT-NNB1 patients were first told they have cerebral palsy. So we share de-identified information like that, but crucially, none of the pharma companies can ever infer based on the data we give them who the patients are. So we have to provide that block. And in fact, it's not just in our interest and in the patient's interest that we draw a pretty clear line. The pharma companies are regulated in a way such that they cannot know who the patients are. And in every single contract we have, they explicitly specify that we as a company would get punished if we accidentally shared identifiable information with them. So it's pretty tight, I think.
It's not only shortening the distance for them to get a diagnosis, but it's like a gateway, right? You're building this community that you're keeping your tabs on, hopefully if they opt in, and you're definitely like shepherding them as long as you can.
Yeah, that's the idea.
Yeah. Dr. Garamella, I'd love to hear about maybe some misconceptions in the nephrology world about genetic testing and why so many of these patients have just been considered, a chronic kidney disease patient.
That's the million-dollar question, I think, and I think this is what we're trying to answer. So I'll start off with, historically, perhaps a lack of understanding of the fact that there is significant heterogeneity in chronic kidney disease. Calling someone as having acute kidney injury or chronic kidney disease is as good as saying you have a fever. Why do you have that fever? What is the cause of that fever? And that's what we're trying to understand. For instance, most commonly, chronic kidney disease and kidney failure in the United States and worldwide is caused by high blood pressure and diabetes. But that does not mean that people cannot have a predisposing condition that has a genetic component that is possibly treated, or a genetic component that triggers an immune reaction that can be treated. And historically, we've looked through this as the lens of uncontrolled hypertension and diabetes, and there has been a lot of patient blame for not having controlled their risk factors adequately, perhaps that has led to kidney failure. We now know that even in patients who have diabetes, who have high blood pressure, we can pick up underlying genetic conditions and triggers that worsen their kidney disease. And I'll give you an example, and perhaps this is the one that comes across as most striking in the kidney field. Persons who have West African ancestry and who identify as Black in the United States have extremely high rates of kidney disease progression and kidney failure. They are disproportionately represented in the dialysis population. They have a genetic predisposition because they can carry a certain proportion of that population can carry two high-risk alleles of a gene called the APOL1 gene, which we know predisposes them to develop kidney failure. People were never aware of this until about 15 years ago, and even now screening for this is not common. So very often we have young, otherwise healthy Black adults who are being diagnosed with having high blood pressure or protein in their urine, and that's just chalked up to uncontrolled blood pressure or diet, and we just put them on medications to perhaps treat that blood pressure. But now we actually have phase 2 and 3 trials that are coming up for APOL1 mediated kidney disease that can significantly alter the course. And so I think it's important to understand why there are treatments. Again, a lot of kidney disease occurs in people of color who have historically been excluded from large clinical trials in kidney disease. So I think not looking at who kidney disease affects and the fact that different risk factors and different genetic risk predispositions exist in different populations is one of the reasons why genetic testing has not been at the forefront in kidney disease. The other thing now is we finally are at a place where the kidney community is embracing the fact that we can utilize this, and just akin to what Lucas just said. For instance, we now have clinical trials of gene therapy in polycystic kidney disease, but for a very small subset of the population, only about 10% of the people. But I think that should not stop us from genotyping these people, because I foresee in the next 3, 4, 5 years trials that encompass all the other mutations coming to the front. And at that time, we don't have to go back and start identifying people. Rather, we already have this valuable repository of patients who we know the exact mutations for and can rapidly get them into clinical trials and get some of these drugs approved. So I think some of these misconceptions surrounding the fact that we don't have a we don't have a cure for a disease, or it's probably just diabetes, or it's probably lack of risk factor control, have really contributed to the lack of genetic testing. And as therapeutics become available, I really see us pushing the envelope in getting more people tested, especially if they have what I would consider red flags for having a hereditary kidney disorder.
What are some of those red flags that would make you want to give someone a genetic test? And also, what role do you see telemedicine playing in this for access?
Oh, that's a fantastic question. So I'll tackle the first part of it, which is what are the red flags? So early onset kidney disease is probably my biggest red flag. Kidney disease most commonly is a disease of aging because it tracks with risk factors such as high blood pressure, diabetes, and obesity. And as the population ages, the prevalence of kidney disease ages as well. But when I see kidney disease in young adults, I don't see children, but when I see kidney disease in adults below the ages of 30 or maybe even 45, especially if they have a family history, an adult with a history of kidney disease and at least a first degree relative with a history of kidney disease or kidney failure automatically makes me think of a genetic condition. In the kidney disease in the absence of diabetes or high blood pressure is a very strong risk factor for having an underlying genetic condition. If they have anatomic abnormalities like kidney cysts, which is what I specialize in, and they have kidney failure at a young age, then that would raise the likelihood of them having a genetic condition. So it's really important to get that family history, because very often we just ask saying, oh, was anyone on dialysis? And they might say no, but they forget to say that, oh, but I had a family member who had a kidney transplant. Maybe they never got on dialysis, or they have a family member who is nearing dialysis, but they don't know about it. So understanding the questions to ask, especially when it comes to family history of kidney disease, is important. Unlike a lot of other conditions, kidney disease doesn't manifest externally. Unless you do that blood or urine test, you don't pick it up. So unlike somebody perhaps who had a family history of heart attacks or strokes, where it's easier to know about, a family history of kidney disease is really hard to ascertain. And that's one of the reasons. And over the last couple of years, we actually now have guidelines, both from the National Kidney Foundation and the KDIGO, which is our governing body for clinical guidelines, that have set out expectations of when to perhaps refer patients for genetic testing. So I think in combination with these high-risk kind of phenotypes that I mentioned, these guidelines will help people who perhaps weren't thinking about genetic conditions to refer patients for genetic testing. The second part of your question, which is telemedicine, is really important because it brings about the question of having the ability to counsel these patients. I can order the test, but if I can't interpret it or provide the patient with the right interpretation, I think it takes away from the utility of the test. There's no point in it, whether that's a positive test or a negative test. And so having partnerships built out both with genetic counselors, with specialized genomic institutes that perhaps you can refer patients to is critically important. And especially in the South and Southwest, perhaps where we have large areas of rural population that are not near large cities, ensuring that you have outreach centers and telemedicine access to them is critical. A lot of the genetic counseling can be done through telemedicine. And for instance, our center here in San Diego offers telemedicine visits to essentially anyone who's referred for genetic counseling, removing that barrier of patients needing to drive into the city, find parking, and come for a visit.
Effie, can I ask a question?
Yes, of course.
I'm so curious. I bet if I was going to ask Michael, should every patient with a cerebral palsy diagnosis just get genetic testing by default? I bet Michael would say yes. And I'm curious, Dr. Garimella, what would be the argument against saying anyone who's got chronic kidney issues should just get genetic testing?
So that's a great question. So I'll answer it because one, it depends on whether you're looking for a targeted variant or you're looking for untargeted variants, because I think very often when I have my variants of unknown significance unchecked, because I am looking specifically for a lot of these unknown causes of kidney disease that are specific to cystic diseases, I look at them and interpret them. Depends on who's ordering the test, and if we have a lot of these variants popping up and causing a lot of concern that may have nothing to do with kidney disease at all, I think there's a potential for patient anxiety. And again, if you don't have the infrastructure to either counsel them or provide them with the right tools, that can perhaps cause more panic. In the vast majority of patients, especially in the older populations, wherein diabetes and hypertension are probably the most common cause, if you have evidence of microvascular disease, heart disease, strokes, peripheral neuropathy, for instance, wherein the likelihood of this being diabetic is incredibly high, and they are, say, in their 70s or 80s, where the likelihood of new onset genetic kidney diseases appearing is low, that's a population I probably would not. But almost in anyone under the age of 50 who has a chronic kidney disease, one can make the argument that it is perhaps worth testing for. I'd be curious to hear Dr. Kruger's take on it as well.
Yeah, I think that as far as genetic testing in neurodevelopmental disorders, it's certainly evolved quite a bit over the last several years. As Cody mentioned earlier, we now have guidelines from the American Academy of Pediatrics as well as other professional agencies, particularly for children with global developmental delay or intellectual disability. When it comes to conditions like cerebral palsy, the guidelines have lagged. And so the most recent practice parameter actually said that genetic testing should not be performed in individuals with cerebral palsy. That parameter is more than 20 years old. And so that was retired, but we're in this state where a number of us in the field are trying to generate additional evidence so that we can make some of those informed recommendations like Dr. Garamella was mentioning. I think we may very well get to a point where it is recommended for all individuals, but it's kind of an interesting transition time right now. And I think if we had solid data to populate those practice parameters, that would be really helpful to practicing clinicians, who are making these decisions every day with families.
And I'll just close out by saying that when I talk to my colleagues over at the pediatric hospital, pretty much every patient that they see has already been tested. They've got their whole exome sequencer there and they test everyone. It's just depending on who you're practicing with and what your patient population is. And I think keeping that in mind is really important.
Lucas, I'd actually like to throw that question back to you too, because I know there are so many critics of direct to patient models right now that maybe do bypass important, clinical safeguards. So what has been your experience with that? And because I know that genetic testing for families is usually a giant turning point, and I'd love to know some of the feedback that you hear from them.
Yeah, it's a great question. So we don't technically have a direct-to-patient model. We have a patient-initiated, physician-ordered model, and this is the patients, when they dig into our notes, they can see that, but they land on our website, they provide us with the information. We then run our assessment of, do we think this person might have a genetic disease? And then the patient's information goes to telemedicine providers, so either physicians who are often geneticists or developmental pediatricians or what have you, or genetic counselors, and they review the patient's information. And if they say, yes, I would order a genetic test for this person, then the person gets testing. And there's a very clear regulatory reason for this, which is for the type of testing we run, so whole exome and whole genome sequencing, you cannot return a clinical lab result without a healthcare provider having said, I want to order this test, and having reviewed the information. People often confuse this with models like 23andMe, where you can just buy a genetic test in like strong quotation marks on a website that's not provider ordered. And we legally can't do that. And I think because of that, we typically don't run into any issues with that. I personally actually have issues with traditional direct-to-consumer models like 23andMe, because I think patients who are in need don't understand the difference between a SNP array that 23andMe runs and an actual diagnostic test, and spend a lot of money on those tests hoping for answers. And then what's worse is not only have they spent money on a test that can't get them results, they get what they think is a negative test result back, and then they think my child or I don't have a genetic disease, not realizing that the test they bought simply can't tell them about, their Friedreich's ataxia or whatever it is. Yeah.
Mm-hmm. Dr. Kruer, how do umbrella communities like neurodevelopmental disorders and other rare disease groups complement each other? And why do we need more cross-pollination with these labels or dual diagnoses?
Yeah, so I think that this is a really interesting and really important area right now, Effie. And like you said, I think that historically, rare disease organizations, especially in the rare neurodevelopmental disorder space, they've often been focused around a very specific genetic condition, for example, or other very specific cause or etiology for the umbrella neurodevelopmental disorder. And I think that a lot of these orgs, they're run by fantastic people. I mean, you know this very, very well. These are amazing people that are trying to create something out of nothing. They're trying to move an entire field forward. They're trying to mobilize their community. But at their heart, especially in the very beginning, these are mom and pop organizations that are run by incredibly dedicated moms and dads many times, or individuals with the rare condition themselves, trying to move the needle. And so I think that there is a tremendous amount of work to be done. And what I've experienced just working with a host of different rare disease organizations, these patient advocacy groups are often trying to move the needle, sometimes a bit in a silo. And I think everybody's path might be a little bit different, but we've been really trying, myself, many of our collaborators, to try to, like you said, cross-pollinate and connect these different rare disease organizations to larger organizations. An example is that we're now working with several individual rare disease patient advocacy groups and connecting them with the Cerebral Palsy Research Network. Cerebral Palsy Research Network serves all individuals with cerebral palsy, and so it is a large umbrella organization. It involves clinicians and families and individuals with CP at a large level. But what we're finding is that there are really opportunities to help one another and to help fill some of those gaps, that in many cases the families can find that there is a sense of community and important supports in both the rare disease world and in the umbrella organization. But we're also thinking about this in terms of things like clinical trial readiness. So as rare disease orgs start to think about wanting to move the needle for their loved ones and try to establish more solid information for their community in the very beginning and ultimately move towards therapeutics, as you know, there's a big gap that has to be traversed in order for rare disease therapeutics to even be possible. We have to know something about the disease symptoms and the characteristics of the disease itself. We have to be able to know something about the natural history of the condition. And we have to have metrics, often referred to as clinical outcome assessments, that can be used to track the condition over time. And I think for rare disease organizations that are trying to develop and establish or populate these clinical outcome assessments on their own, it can be very difficult. And so by finding that common ground, we've seen a number of examples where rare disease organizations have been able to help one another. And also we've seen that cross-pollination where a rare genetic form of CP, for example, might not need to develop their own very specific clinical outcome assessment. They might be able to essentially borrow something that's already been established for the broader CP community that translates very well to that very specific rare form of CP. And so I think that we're going to see more and more of this over time because, for example, we did a recent survey and found that there are actually almost 200 individual organizations that are serving different rare forms of cerebral palsy. And so I think that the more that we can, as a broader community, pull people together and help each group avoid having to reinvent the wheel, I think the better off we're all going to be.
That sounds like a dream. Lucas, how can AI sort of implement this idea and gather all of these groups together and sort of help them work together without putting all of this extra work on the shoulders of these patient advocacy orgs? Like how can this work in a more streamlined and quicker way with AI?
There is a simple question.
Can you make it, Lucas?
I can tell you, I can tell you one thing that we're doing, and then one thing that we're thinking about, and I think that, and then one thing that's going to happen. But none of these are going to be perfect answers, I'll be honest. Um, the the one thing that we're doing is we sometimes call this like the Harry Potter sorting hat. Is we built one platform that's supposed to identify these patients, and patients come into the platform from all different walks of their diagnostic odyssey. And very often we get patients in who think, I'm pretty sure I've got this disease, right? They've read a CTNNB1 post and they're like, that sounds exactly like my kid. And then they come in and we test them and they actually don't have CTNNB1. They've got something else, like a different gene, very related phenotype, but different disease. And if somebody came in, let's say from, let's say from your podcast, Effie, and they heard about CTNNB1 and they're like, I think I have CTNNB1 and they don't have it, but they have something that a different advocacy group exists for, then we automatically funnel them to that different advocacy group and tell them this is your tribe, and vice versa. You know this. We and Michael knows this too. We ran a big program on AEDC deficiency. Different type of genetic disease that presents with cerebral palsy, and we would get people in, and we thought they might have AEDC based on like early phenotypic presentation, and they actually had CTNNB1, and then we funnel them to you. So that's like an easy thing that AI can do. The Harry Potter sorting hat, match them to the right house, essentially. Then the thing that we would like to do that we haven't done yet because we just haven't had the time is when patients submit information to us, they talk to an AI and they share so much valuable information, and we want to match them to other patients in our platform who've said very similar things. Like we have people who have a specific disease and they're like, and I have shooting pain up my left lower leg, and I also have this other thing. And those people should be matched to other people who've described the exact same thing so that they can start talking to each other. We've not done that. And then candidly, I think the biggest thing that's going to happen over the next 5 years is the ARPA-H Rapid program, which many of you or some of you might have heard of. For those of you who have not heard about this, the ARPA-H is a government institution. It's a branch of the NIH, sort of, that has dedicated tens of millions of dollars, maybe hundreds, I don't know the exact budget, to eradicate the diagnostic odyssey. And the core focus of the program is let's develop 2 different AI technologies to do this. One of them is going to be AI deployed in EHRs. Let's find all the patients in EHRs. And the other one is going to be AI deployed direct to patients. Let's find all the patients we can find via direct to patient. And as part of that effort, and this is how I'm going to tie it back to your question, Effie. As part of that effort, like a phenomenal amount of community building is going to happen because we're going to have to identify all these already known patients, collect data on them, train AI, and then build based on this one massive investment the government's doing, all the patient advocacy groups out there and sort of like, raise all boats. So I think the patient ID part of it is going to be solved by this big investment and by AI. But for like what Michael was talking about, how do we use AI to make sure that not all advocacy groups have to repeat other efforts? I don't know if anyone's working on that. I think they should be. Yeah.
It would save some money and a lot of headaches, I'm sure.
Yeah.
We're trying to.
So what role,
Funding pending.
yeah, maybe to all of you, what role do patient advocates and rare disease organizations play in driving testing forward? I know most people who are probably listening to this presentation have some sort of idea or have had genetic testing. So how do we create this army to help others understand that, hey, maybe go get a test? And then maybe back to you, Dr. Garmella, you mentioned that you are trying to, or not trying, you're practicing teaching other medical professionals in, getting genetic testing frontline. So how are you educating the clinicians? And then also, how can we educate our rare disease orgs to help?
Yeah. And I think both those groups are really important because, one needs it and one right now has somewhat the control to be able to deliver that, right? So we need to make sure that both of them work in tandem. with regard to the clinician aspect of it, I'll talk specifically about kidney disease because that's what I'm extremely involved in. We partner with companies that offer genetic testing to run a lot of clinician-facing continuing education, continuing medical education seminars. We go out to the large conferences that each organization has, whether it is the American Society of Nephrology, the National Kidney Foundation, the Renal Physicians Association, because we're not just looking at academicians. We do not want genetic testing centers to be these ivory towers floating in a sea of mediocrity. We really want genetic testing to be available to everyone out there. And so if the private practitioner in rural California wants to order a genetic testing, it's easy enough. The genetic test comes home, people swab, they send it back, they get the results. How do you interpret that? How do I connect them with? And a lot of these companies now have support systems where they can actually contact both the patients and the providers to provide genetic counseling, because it's not just the patient who needs it, but you might need to provide that same education to the provider. So we provide them with the indications, the framework, how to streamline the process, talk about how to make sure that the indications for it are covered. Testing, sometimes patients are concerned whether or not their insurance will cover it, and make sure that clinicians understand that while we are trying to find a cause, there is still the likelihood that a genetic test will not yield a result. Because once you don't get a result, it's very often stuck in your head saying, oh, I ordered a genetic test on that patient and nothing came back. I'm not really sure it's worth it. So understanding that each patient is different that you're looking at and the indications may be different, not letting heuristics necessarily drive how you practice your testing for genetics. And so we do that. As a faculty member in an academic institution, we have training programs geared towards our residents, especially our fellows in nephrology, because this is an emerging field, so that when these fellows now go out to practice nephrology anywhere, they understand why genetic testing can be done. We get them access to the genetic testing portal that we do it through so that they can actually look at the results. Every time I get genetic testing results back on a patient I ordered it, I sit down with the fellows and discuss it with them. And then we have sponsored education sessions for these fellows as well, wherein we discuss challenging cases, whether it's within nephrology, but very often a lot of these genetic conditions span specialties. We have colleagues in neurology and cardiology that we need to have genetic conferences with. So again, getting the word out there that we are able to test these patients and it's probably going to be beneficial to them is the message that we are getting out. With regard to the patient advocacy organizations, I think it's critical. Within the American Kidney Fund, we have the Unknown Causes of Kidney Disease Project, which brings together patients, clinicians, industry partners, and other stakeholders to develop some of these testing guidelines and educational guidelines. We have another project called ARCDAN, or the Rare Kidney Disease Action Network, which again helps bring in industry partners, people from the NIH as well, and also advocacy groups, so that we can identify patients who can rapidly be directed towards clinical trials. And so, that's what we're doing. That's what I'm doing personally on the clinician front at the individual level, and then what the American Kidney Fund is doing at a larger level to disseminate this. The other thing we're also working on is working with primary care providers, because me as a specialist perhaps have a biased view. I have my antenna go off anytime I think about a genetic diagnosis, but educating the community physicians, the primary care providers, on when to think of a diagnosis. Maybe they don't need to order that genetic test and interpret it and do all that follow-up, but either order it or refer for genetic testing. Consider that as an option. I think is important. When we talk to individual patients, we actually have a web portal that says, know your disease and know your cause. So the patient can actually answer a series of questions that have branching logic that then directs it to whether or not they have had ultrasound imaging, whether they've had a kidney biopsy, whether they've not had genetic testing, and why it might be useful to talk to their doctor or provider about the utility of genetic testing. So that's what we're doing also at an individual level.
Lucas or Michael, do you have anything to add on the role that patients, families, orgs can play in accelerating that future?
Yes, I have some data that I could show.
Show us that data.
I didn't, Daniel, I'm sorry, I didn't send it to you beforehand. I was supposed to. Um, Patient advocacy groups are super powerful, and I think I'm just reiterating a portion of what Dr. Garimella was just saying, but not only can patient advocacy groups educate patients, you can also educate doctors because most doctors don't know much about genetic testing. And I'll show you like an analysis we did that shows in our own data that this is happening. And I'll walk you through it. This is a technique from network analysis, like Facebook and social media companies will do analyses like this. And what I'm showing on the left side is in red patients and in blue doctors. And we try to understand how many patients are referring doctors into our system. And so here you can see we started with 12,358 patients in this case who told us that they're seeing a total of 28,536 doctors. And then we can see, and then those doctors referred another 38,000 patients into the system because their patients must have told these doctors about it. And then from this mass of 50,000 patients, we got another 9,000 physicians, and then those told even more patients about it. And with that, over 12 hops in this like network analysis, you go from 12,000 patients initially to 77,000 patients that came into the system to get genetic testing. And the important thing about this is $0 were spent on this. Like this is not a massive advertising effort or anything. This is literally just patients who found out about genetic testing telling their doctor, I think genetic testing is helpful. Maybe think about it. Or they might have even just told their doctor, I got this test done. So this is like super, super powerful. If you got a genetic test done, tell your doctor because they might go and test another patient. And I think the other reason why this is important is we all know we only have treatments for 5% of these rare diseases. For the other 95%, we have nothing. But a crucial contribution that everyone can make by getting tested and by helping get other people tested is to build a stronger case for drug developers to start developing treatments, right? If they think the patient population is small, or if we don't have enough data to understand how do these genes work, nobody's going to develop these drugs. But if you can get other people into the fold and get them diagnosed, that accelerates drug development.
I love it.
Amen.
I love it, Lucas. And I have to say, I mean, the data speaks for itself. It's very
Yeah.
powerful. I would just, briefly add that I think that on one level it's very simple, and at another level it's quite complicated. But it goes back to that concept of asking why. Don't just accept a descriptive diagnosis. And I think that goes for both providers, as we've heard, as well as the patients themselves. We all know that medical practice is slow to change, but I definitely take heart in the slope of your curve there, Lucas. I mean, these changes are happening, and so I think that the more that we can contribute to this, the more it's going to feed forward.
Yeah, and just personally, I've found, someone mentioned our primary providers, like my son's pediatrician, who has, no window really into rare disease other than her one patient, who is my son. And I find that she's very, very amenable to listening to things that I bring her because she probably doesn't have time to research any of this at all. But she's interested in what I'm learning from my community, especially when I bring charts like what Lucas just shared, or papers that come from CT and NB1. And she's so open to like helping me figure things out, but also bringing it to her own patients in the clinic. And I think that one voice can help multiple patients, and it really just opens their eyes to just thinking a different way when they see something when a patient comes in. And they really do listen to parents because they know we're the experts. And I don't find that I have so much pushback anymore from primary care providers. And maybe it's just time. And with all the work that the three of you are doing, has really helped that conversation in the clinic.
No, that's fantastic. A lot of my patients bring me literature. They actually bring me published articles that I probably wouldn't have seen. And I'm supposed to be a specialist in that field, right? But I might not be hyper focused on the one thing like they are. And so this really helps me. I've had PhDs who have the disease who come to me and say, can we look at the slope of change in kidney function on these graphs? And I'm like, my eyes can't tell the difference, but they can. And speaking of advocacy, I think, it's really important for clinicians to partner with patients and advocacy groups. Show up to show your support, help understand that you are there, willing to learn, willing to take these steps with patients. Because having that discussion with a clinician can be uncomfortable, saying, hey, what do you think? Or would you send me for a second opinion? Or I want to see someone else. But I'm really, glad to hear that your pediatrician has been, open to having those discussions. And I can't tell you how many times I've met clinicians who are nihilistic about genetic testing. Perhaps, because of what Lucas said, we have treatments for 5%, right? For 95%, I can't offer anything. What's the point? But that is one of the barriers that prevents us from actually reaching the next step and next goal. You will not find a patient with breast cancer today who does not get genetic testing, right? We look for every gene, every mutation on that panel. 30 years ago, 35 years ago, perhaps we wouldn't have. And I think in a lot of diseases, perhaps today we are where things like breast cancer were in the late 90s. And hopefully in another decade or so, we will all rapidly catch up, given how available and interpretable genetic testing is becoming.
Mm-hmm.
Completely
We
agree.
have we have a couple more minutes until the Q&A. So maybe to go off of what you just said, maybe to all three of you, if we were having the same conversation 5 years from now, which I feel like we did 5 years ago, but if we were having the same conversation 5 years from now, what would you hope has changed?
I would hope that we're seeing more of clear clinical implications. We're seeing, that this increased uptake of genetic testing, and we're getting more specific causative diagnoses, and so that we have those dual diagnoses, and it's not just chronic kidney disease or just a diagnosis of epilepsy, and we don't know why. But I think in concert with that, also seeing that rise in the clinical implications or the actionability. So Lucas was mentioning, if you look at 5%, if you look at rare disease as a whole, perhaps 5% have specific treatments. But breast cancer is a specific example where the growth in knowledge has really transformed the field. At a small level, in cerebral palsy, we now have data that shows that for more than 1 in 4 individuals who have a genetic form of CP that's identified, that actually impacts their care right now. And I think that in 5 years, we want to see those numbers improve for many, many different conditions.
I would say that I love the 5-year timeline because that's almost exactly the timeline for that ARPA-H project. So my hope would be that in 5 years' time, the diagnostic odyssey doesn't exist anymore because patients get caught by AI in the EHR or in direct-to-patient systems, and then they can get diagnosed really quickly. So 5-year ambition is no diagnostic odyssey.
I will temper my hopes, and I will say that in 5 years, I would like pretty much every clinician to be using the tool. Whether or not we have completely diagnosed everyone, I think that the first step is getting everyone to use the tools we have and disseminating that knowledge. And once we do that, we will actually close that gap of the diagnostic odyssey. So as we build this, as we have more conversations around this and patients start talking to their physicians, and I love Lucas's graph. So, maybe 5 years from now, that we will see a takeoff of that graph and, pretty much every clinician will be using it.
Yes, I love it so much. Thank you three so much. I think we could talk about this for a long time. I mean, I keep thinking about going off into ICD codes and how a diagnosis actually does change things. But I'm going to hand it over to Daniel. And I know there's a bunch of questions in the chat. And
Yeah, thanks,
there goes
Effie.
my box.
There definitely are a lot of questions and really good ones. There's a few that I'm going to sort of combine into one that are around the differences between WES, WGS, and microarray, the different types of testing. And if any of you could sort of break down the better use cases for each of those. And one person is asking, is it always cost dependent? And then another person takes that another step, and Tina is saying, is it recommended to retest? She had whole genome sequencing if the original test was 10 years ago. So if any of you would like to take that one.
I can take that one. So when I think about this, and I talk about this with my patients and families, a lot of times I like to use a cookbook analogy that, our Our genomes are essentially represent a cookbook or a recipe book for how to, create a human being. And inside that cookbook, there are many different recipes that are reflected as genes. And so when we're thinking about the types of genetic testing to do, for example, we could do a microarray, and that looks to see if there are, for example, whole pages that are missing, torn out of that recipe book, or that are perhaps duplicated. And so that can play a role in identifying genetic causes of different conditions. If you look at whole exome, that's like speed reading through the cookbook and trying to just very quickly look at the core letters that make up the individual words or the individual recipe. And so it does catch the majority of things. But I think of whole genome sequencing then as a more careful read, where you're literally going kind of line by line and letter by letter to make sure that there are no typos that your eyes might have missed the first time that you see it. And then there's even further levels. So there are additional techniques that can look at other types of omics that can be complementary to what's done in this different type of genetic testing or sequencing. And there's even something called long read whole genome sequencing that's able to find other types of genetic mutations or genetic variants. And so in regard to the question about repeating testing, I think that the technology has continued to improve. I liken it to the way that the computers continue to get better, faster, and smaller, or the way that cameras over time have had better, better and better resolution to the point where you can get a photo that looks almost more realistic than real life, what I see with my eyes. And so I think that there can be value in going back, but it depends upon the individual scenario. And something that probably would be worth discussing with your healthcare provider.
Great, thank you. Lucas, we have one specifically for you. Randy is asking, they've already gone through genetic testing and have their diagnosis, but hearing what you said, Randy is interested, could he participate in your platform in order to get those sort of alerts and updates of what could come next in that disease area?
I love that question. Yes, please. And I also there was somebody else in the chat, Abby Cook, who talked about their child's diagnosis. And everybody who submits to our platform, if you have a diagnosis already, you help us train the system and make it better at recognizing more patients. So it is you get the alerts, but it's also super helpful for us. I'll put the email address of a team member of mine into the chat who runs that entire effort. And if anyone would love to contribute to it and help us collect training data so we can find more patients, that would be amazing. I just posted it.
I thought your answer would be yes. I'm so glad it is. Amber is asking, for those of us that don't have a family history with the same disease, how can a genetic test benefit us?
I can start off answering that, and then I'll let the two of you talk about it. I think that depends on what kind of genetic testing you are looking at and what the disease the other family members have. The heritability of it, is this a recessive gene? Is this a dominant gene? For instance, is there an age by which all symptoms manifest, and is it worth looking for it in situations where disease hasn't manifested yet, which is, I think, the big question. From the perspective of patients who, in my field at least, are looking to help their family members donate kidneys, etc., we absolutely do genetic testing because it not just informs their risk, but it tells them whether they can literally save someone's life by donating a kidney to them. So in any family members who have a genetic condition, one other family member leading to kidney failure, we absolutely test them. The other time we would test family members is if they are considering family planning, pre-implantation genetic diagnosis, whether they would like to undergo IVF. That determines whether or not we would offer genetic testing. If we have treatments that detect some of these conditions early on, for instance, if we're looking at immunological markers of a condition that can be detected in the blood. If you have one of these mutations, we would perhaps screen you more often. An example of that is a high-risk APOL1 gene, for instance. Patients may not yet start developing a protein in their urine. We would probably screen them more often and then provide them access to clinical trials. I think those are at least within the realm of kidney disease where we would use the genetic testing in patients who have one affected family member.
Thank you.
I'll just briefly add that just because there's not a family history doesn't always mean that it's not genetic, like Dr. Garamella was saying. And one of the important reasons that we see this in the neurological disorder space is that a lot of these are so-called de novo mutations, where they actually occur spontaneously, and they're found in the child, for example, but not found in the mother or the father or anyone else in the family. And we know just through research over time that on average there are between 50 to 100, perhaps more, genetic changes that are inherited, or excuse me, that occur spontaneously from one generation to the next. So that's always a possibility.
Thanks. This next question we've heard at Global Genes many times, and in fact, I'll give part of the answer that we had tried to address this with a session maybe a year ago called My Genetic Test Says VUS, Now What? But the question is, how do I get a clarification when my genetic results say VUS?
I can try to tackle that. I don't have a perfect answer for you because we haven't solved that particular problem completely. But I will say that this is something that, going back to the prior question asking about genome sequencing performed 10 years ago, is there any value to revisiting that? I think the answer is potentially yes. And that's because VUSs over time, they do, in general, tend to be able to be better classified. We still have a lot of VUSs. We still have a lot of things that we're trying to learn. And just because there's a variant doesn't always mean that it's an issue or that it's linked to the condition of interest. But as medical knowledge progresses, there's been more and more progress in resolving VUSs, and some of this is being done through careful experimentation in laboratories. Some of this is being done through multi-omics. Some of it's being done through AI techniques that will, for example, incorporate all that's known about the condition and about that person's clinical symptoms, sometimes even taking into account facial photographs. And Lucas, you may want to speak about this as well, but that type of information can help take a VUS and make it something that we're at least a little bit more certain about in some cases.
Yeah, I can add 2 sentences to that. Depending on the reason why a variant is classified as a variant of uncertain significance is not always the same. As Dr. Kruer was saying, in some cases it's because we don't have sufficient biological evidence yet that tells us no, with certainty this is causing disease. In other cases, it can be we don't know if the patient's symptoms are a perfect fit for the disease that this variant would cause. And so for the latter category, today we have some AI methods that can help reclassify those variants of uncertain significance. That's not our work. There's a research group that developed an algorithm called Gestaltmatcher, which you can basically upload a photo into, and then it makes a disease prediction based on that photo. And they can also use that same algorithm to reclassify some variants of uncertain significance. So if the person who got the VUS back has a facial phenotype, or maybe has a facial phenotype, techniques like that in some cases can be used to reclassify the variants. But it's an evolving field. The other thing that I'll say is there's not a ton of stats about VUSs out there, but I think one of the most reliable sources I've seen estimates that 75% of variants of uncertain significance later get reclassified as likely benign or benign, meaning 75% of those variants are actually not the smoking gun that's causing the disease. So it's just important to really view them with appropriate caution and not think that's my definitive diagnosis if you get a VUS.
And for those of us in clinical medicine, often I get VUSs and I make it a point, especially if I have a high clinical suspicion, to actually go back to the company about every other year or so and say, hey, has this VUS been reclassified since, in case I've missed it, or look it up every couple of years in ClinBot or some other database to see if it has been reclassified, because that would be when my clinical likelihood of that gene being attributed to the phenotype that I'm seeing, that would make it much stronger.
Great, thank you all. Another question came in. How can we improve access to genetic testing and ensure earlier, more precise diagnosis for children of color that may be affected by rare diseases?
I can start on that, and I can't speak to children of color specifically, but because in my world, kidney disease affects people of color more. But I do think that what we're doing right now in terms of really engaging with the patient community and building that advocacy, asking for that test, and letting clinicians know that you would like that test, and highlighting the fact that there are possibilities that they might not be thinking about, is really the first step. As clinicians, we're trying to keep abreast with a lot of information, and sometimes, the genetic testing, depending on whether or not it's in-house, whether or not we have a genetic counselor, whether or not we know how to interpret it, may inhibit us from actually ordering that. And while that is something that we are working on, building partnerships with rare disease organizations, enhancing those continuous education models and working with the advocacy groups, I think is critical. I cannot overstate the importance of having patient voices in getting more access to testing and improving testing rates.
There's a question which I think may give us a chance to clear up some misunderstanding of which doctors, which specialists can and are more likely to seek genetic testing. The question was asked by Jin: can primary care doctors prescribe whole genome testing and still get reimbursed for it?
So I don't think any of us are primary care doctors on the call, but I can take a stab at that. I think that from my experience, potentially yes, a primary care physician could order exome or genome sequencing. I have seen it done. I think that the training that primary care doctors receive in interpreting some of those findings is an area that we would like to see improve over time. But I do think that is a possibility. Sometimes because the questions are specialized that drive the need to, or the desire to get genetic testing, it at the current time more often ends up being a specialist in that particular area. But I think that there are some very interesting implications of that that hopefully will evolve over time.
I can just make one addition, which is there are telehealth services that can prescribe genetic testing and submit for insurance. And if you had the experience that maybe your PCP tried and didn't succeed, or you don't have a physician who's willing to do it, there's one service called Genome Medical, which does exactly this. And it's not free. Your insurance either has to cover your Genome Medical appointment, or you have to pay for it yourself, which is $250. But I don't know this for sure, but they might have a higher success rate in getting you insurance reimbursement. So overall, it might actually be a cheaper route.
Thank you. Let's see. We have a number of questions. I don't think they would serve us unless any of you tell me you're expert or somewhat knowledgeable in blood-confined chimerism. So I think for the sake of general information, we might not address those in this forum. So here's one specific to, and I'm curious myself, is it certain specialties more comfortable ordering genetic testing? Because this one is about neurology. How are neurology teams handling the results of WGS, whole genome sequencing? And do they order testing and schedule genetics for a follow-up on all findings, or do they have a team that helps handle those reports in the clinic? That was from Andrea.
Yeah, I can say at our center and from what I've seen at other centers, it really does vary. Depending upon the setting in whether it's academic or more private practice, then you might see different patterns of genetic testing ordering. For example, some neurology groups would be, tend to be relatively comfortable ordering the testing and doing some of the interpretation. Others routinely refer to our colleagues in clinical genetics. I will say that I think in general, neurologists are a bit more comfortable in ordering the testing, and then perhaps maybe a little bit less comfortable with some of the nuances of variants of uncertain significance, VUSs, or in some of the implications of testing that might fall outside of the realm of neurology. So I think that it can vary, but really most groups tend to take a team-based approach where there might be some different levels of expertise, but they tend to support one another, and hopefully should have a mechanism in place in order for that family to get the answers that they deserve from that testing.
Thank you. This next question, I think, goes to the idea of when patients sort of find themselves, or patients or caregivers find themselves driving their medical team, perhaps in directions they're reluctant to go. So the question is, how would you convince doctors to skip chromosomal microarray and karyotyping? How would you convince insurance companies to pay for and instead order karyotyping? How would you convince insurance companies to pay for the more expensive karyotyping?
Are they asking, saying, how would you perhaps go to a whole genome sequencing that would
I think that is it, to go beyond,
well, rather than just a targeted panel? That's a hard question right now, and I think I think some of this relies, and that's why I was also talking about how we document and why we make the rationale for it, especially in unknown kidney diseases. For instance, I think I saw some questions whether Medicare or Medicaid would cover it, and typically, yes, most of these are covered also by Medicare and Medicaid that I have seen. But depending on the disease spectrum that you're trying to diagnose and whether having an absolute negative test is needed, one can argue for the need for whole genome sequencing as well. It's not something I order too commonly. I don't know if Dr. Kruer or Lucas, you want to comment on this in terms of the financial impacts of getting the whole genome sequencing as opposed to a targeted.
Yeah, I can say that I think that it has become more widely available. I do think that in this particular case, most insurance companies, for a lot of the neurological indications at least, will support or cover the cost of exome and or genome sequencing. I think, though, that this is where the indication does matter, and sometimes we will still get pushback. And so I had mentioned the importance of practice parameters earlier. I do think that these are kind of the clinical guidelines that a lot of practicing clinicians will refer to when trying to determine what types of workup or what types of diagnostic testing are done. And so the more support we have from these types of clinical guidelines, I think that helps to ensure that patients and families get access to these types of tests and that insurance companies cover them. I will say that if you are getting pushback, sometimes this can be something that can be appealed. We certainly have done our fair share of talking to medical directors and trying to work through the insurance process, and sometimes just making the case that, hey, that this could actually impact care, and providing documentation of that can be a very powerful argument to get the testing and why it should be covered.
One thing that patients can also do is we run free testing programs. If you just go to our website, the main button right at the top is our intake. You can submit your information, and the telehealth is free, the testing's free, it's all free. And in that way you can get a free exome or genome test as well. If you have a disease that is in one of the disease areas we currently cover. We don't cover all disease areas, so you might not get lucky, but it is one path that's it doesn't cost anything. You can try it quickly. Yeah.
Thank you all. This next one actually is not really a question, but I want to share it anyway, since it seems to be a success story. Tim has shared, I've been diagnosed with a rare disease through genetic testing, found a defect that qualified me for an NIH clinical trial to prove the effectiveness of a targeted immunotherapy drug. My treatment worked well for me, and I'm now defect and disease free. So I think we should celebrate the wins when we find them, and way to go, Tim. Kelly is asking, curious to hear your thoughts on finding a diagnosis in non-coding genes via whole genome sequencing. How deep are we into studying and discovering non-coding genes? Do you foresee any breakthroughs in that area in the near future? Her son was just diagnosed with Renew syndrome a few weeks ago, a non-coding gene syndrome with gene RNU42.
I will say that I think that's an exciting area. A lot of variants in non-coding regions are a bit more difficult for us to interpret at this point in time, and so a lot of them do end up as VUSs. And so I think with some notable exceptions, as was just mentioned, but one of the ways to circumvent that is to aggregate data in ways that you've already heard about. Lucas mentioned that. I think that there are a lot of other exciting initiatives underway to try to reduce some of the silos between people and organizations and try to aggregate data so that we can better interpret these variants. There are also different types of assays that can be done, and those are being actively pursued, but this is not something that is an easy problem to crack at this point in time.
All right, thank you all very much. I think we will let that be the last question. We do have a few things to just wrap up with here. I want to thank all of the panel and also Cody Barnett for sharing your knowledge with us, and let people know that there are resources related to this topic. I think we can add some of these to the chat so it's easier to actually click on the links. But for anyone who takes our survey after the event, you'll get these slides and you'll have these links that way too. Some of these great resources come from Global Genes and some come from our panelists, and some are on Effie Park's podcast. I pulled out a few relevant episodes that she did. And here's a few of the points we hope that you will remember as you walk away from this session today. Again, that survey, if you want to, we'll be emailing it out to everyone, but if you want to grab it right now with a cell phone camera, you can use this QR code. And coming up next month, the last session in this series is Knowing the Rights for Your Rare Child or Yourself. Kelly Coleman is author of a great book for rare parents, and she'll be moderating that panel with Michelle Irwin, who is a spinal muscular atrophy mom and leads the group All Wheels Up, which, if you don't know it, you should look into. It is fiercely fighting for advocacy of travel, wheelchair rights, travel on airlines in particular. And Benita Talati is living with a rare disease herself and an attorney for disability rights. So that's going to be a great discussion. We'll also get into school issues like IEPs and 504s. So join us next month for our next and final panel in this series. And again, thank you to all of these great sponsors who make this possible. We couldn't have events like this without them. So thank you again to Effie, Michael, Lucas, Pranav, Cody. It's a great, important topic and a lot of great insights into it. I'm sure we could have gone even longer if we had scheduled more time. So that is our session. Thank you all.
Thank you so much.
Thank you.
Thanks so
Thank you so much.
So much, everybody.